This session on neuro-ophthalmic disorders. We're going to be having some interesting discussions today. I invite on the dais my chairperson, Dr. Naveen Jaikumar, co-chair Dr. Ambika, Dr. Swati Fulgere. Myself, I'll be moderating the session. If you have Dr. Mahesh, Dr. Kumudni, Dr. Vrinder Sachdev, all please come on the stage. Dr. Shikha Basi and Dr. Suchita. Now we'll start with we'll start our session without much ado with the first talk by Dr. Clement Tam, and we're going to discuss visual fields in neuro-ophthalmology. I think something which has been a very, very important tool for all of us to diagnose and manage neuro-ophthalmic cases and localizing the lesion on that.
Morning, and I want to thank the organizers for inviting me to speak about visual fields. I thought this would be very straightforward because everybody in medical school has already figured out the visual pathway, and all good students will have memorized this already, and so you know a hemianopia, where in the brain to look for a hemianopia, whether it's homonymous or it's bitemporal. It's quite straightforward. There is not much more to localize it. So I thought a few things that are worth our attention. First is to understand that anatomically the what is called the retinotopic organization of your visual fields, and to understand that in the brain, the central 10 degrees of your vision is represented by slightly more than half of the primary visual cortex, and the central 30 degrees will be represented by 80% of the primary visual cortex. So as foveate animals, a lot of our brain's surface for vision is taken up really by the central vision. So it probably tells us why if you do a 24-2 or 32 on a Humphrey, you will get a pretty good representation of most of the brain, right? But if you really want to be complete, then you have to test the entire extent of the 160 degrees of your visual field. But think about it, right? That's why the central vision is so very important, and the glaucoma people will just get away with a 24-2 all the time because that really makes up most of what our perception is. We all know that there are many methods to doing it. Confrontation, there are about as many methods to do confrontation as there are people doing them. The tangent screen, I'm not sure if anybody still does a tangent screen. It's probably useful in low resource settings, or if you're trying to determine if someone is malingering or has functional loss and you're looking for tunneling of the visual fields. So the germ screen we still have one, and my old mentor Barry Cullen insisted that we buy one for the clinic, so I duly put in one, but it has not found that much use. I've used it mainly in the military when I'm screening some of the soldiers for functional visual loss. Kinetic perimetry, the Goldman is still very much useful, and now you have a Goldman kinetic perimetry built into many of the Humphrey perimeters, some of the octopus or the Humphrey perimeters as well, and of course we have our usual static perimetry. We're all familiar with this, as I mentioned earlier. For example, if you see a superior quadrantenopia, you know it's the temporal lobe. Inferior quadrantenopia, maybe it's the parietal lobe. And homonymous hemianopia, any sort, just tells you it's on the other side. Of course, there are some special ones like the sectorinopia of laterogeniculate nucleus lesions, typically incongruous. I must say they're pretty rare and hard to find. It's difficult to pick this up. It certainly doesn't really show up on a Humphrey perimetry, and you really only get it when you try to do a good kinetic perimetry. So it's an interesting feature, but quite hard to detect otherwise. Okay, some guidelines that I think are helpful for us to observe. First of all, optic nerve lesions cause visual field defects corresponding to one of three major nerve fiber bundles. I'll show that in the next slide. And they typically originate from the blind spot, and they don't usually respect the vertical meridian. So they don't usually respect. So they may look like they do, right? Lesions at or behind the chiasm, you will get hemianopic defects. If you have a afferent pupillary defect, it suggests that you are in the anterior visual pathway just before the laterogeniculate nucleus. And if you have homonymous hemianopias, the nearer to the occipital cortex, the more congruous the visual field defect. And if you happen to see macular sparing, which I think is really hard to show on static perimetry and typically shows up on very good kinetic perimetry, then macular sparing usually indicates an occipital lobe lesion in the context of ischemia. So I want to spend a little bit more time talking about optic nerve type visual field defects, because we are often called upon to distinguish this from, say, to tell whether this is glaucoma or it is something else. Okay, so as I said, they start from the blind spot, don't usually respect the vertical meridian. They typically affect the papillomacular bundle, the arcuate bundles, and the nasal bundle. Okay? And visual acuity is typically affected if you have something affecting the optic nerve, right? And so look for visual acuity changes, color vision changes, and an afferent pupillary defect. This patient has a inferior altitudinal, it looks like an inferior defect, right? It seems to have crossed the midline. So you say, well, is this an inferior altitudinal defect or not? But then if you do the kinetic perimetry, it really can show you how it respects the horizontal midline. Likewise, this patient has just a totally black visual field defect on a Humphrey perimetry, but when you do a kinetic perimetry, you see really it's just a large central scotoma. Bear in mind that a Humphrey really does 24 degrees of your visual field, therefore everything going wrong in that 24 degrees, if that's the only place it will go wrong, really is just one form of a central scotoma. And there is a very, very nice old study that demonstrates that the utility of the kinetic perimetry versus the static perimetry in distinguishing between what is a central scotoma or an altitudinal defect. Because if you remember the optic neuritis treatment trial, they said, well, it can cause any type of visual field defect. So why did the old books always talk about a central scotoma? It's because those old textbooks were written in the days of kinetic perimetry, before static perimetry even existed. How about these patients, right? They look like, this patient looks like he has a temporal loss on one side and maybe a little bit of loss on the other side. But when you do the kinetic perimetry, then you can really see in that left eye that central visual field, the largely central visual field defect that this patient has. It turns out this patient had Molk disease. And how about this? Bilateral disc swelling with, well, not very prominent defects. But if you look at this is a patient with papilledema, and so if you can imagine it, then perhaps you can see that in the right eye, the patient has an enlarged blind spot. In the left eye, maybe the blind spot is enlarged, but maybe some scattered non-specific defects. So I put this here to highlight that papilledema can give you almost any type of visual field defect and not just the enlarged blind spot. These are other examples of papilledema where you just see generalized constriction, which I've put there on the 120-degree visual field, generalized constriction of the visual fields, and maybe just, non-specific visual field loss, which you can see on the 24-2 visual field there. One very useful tool here is what has been described as the temporal raphe sign, which is something you see on the OCT. And so if you have a superior nasal visual field defect, that's the top row of this series of pictures, and you can match that to an macular GC-IPL thinning that respects the midline, the horizontal midline or the temporal raphe, then you most likely have a glaucoma. But in the second row and the third row, again in the second row you have a visual field defect. It looks just inferior and one quadrant, but the macular GC-IPL does not seem to match. So I think what we are learning over time is that one ought to look at the macular GC-IPL besides the retinal nerve fiber layer thickness to help decide what kind of a visual field defect this is. So in brief, have a good physical examination, right? Color vision may help, OCTs help, and then if you have access to electrophysiology, now that is definitely helpful, because if you have just pattern ERG abnormality without a VEP delay, you probably have a macular lesion if it's just the P50 is affected. So I do recommend electrophysiology in cases of doubt. This patient looks like she has a bitemporal hemianopia, and that's how she presented. Actually, she initially presented with as glaucoma and had TRAPS done and cataract surgery done, and then someone said, but the pattern looks a bit bitemporal, and so they sent her for a scan, and the scan, nothing, normal. So we did electrophysiology. Then we looked at this and said, but her macular GC-IPL is all completely thinned out. but her nerve fiber layer is still relatively good. So something else is wrong down here. It's in the, when you do the autofluorescence, and you can see the hyperautofluorescence, and it's in the retina, and she has a photoreceptor abnormality, diffuse photoreceptor abnormality. So don't forget the electrophysiology, it is your friend. So finally, just consider doing more than one type of visual field testing. If you have hemianopia, it needs neuroimaging. Do the OCT macula, RNFL, and GCIPL to cross-check and entertain a healthy suspicion if fields and OCTs don't match. And don't forget our friend electrophysiology. Thank you, and I'm sorry I ran a little over time.
Thank you. I think that was beautifully described. The good thing about a lot of these neuro-ophthalmic fields is that they're good patterns that you can look at and you can decipher, and but at the same time they continue to be deceptive in certain ways, which is why I think one of the recent papers just come out on AI, where they're trying to use these patterns to get AI to train. Even the AI seems not to perform as well as probably our humans do, but very interesting. Any comments, sir, from your side? Well, with that, we have Dr. Kaman Chan is here. She's not. She's at the other session. Then we have Dr. Rohit is also. So Dr. Ashman is also. Dr. Naresh Mutani, would you? Yes, I think then we'll start with you.
Spoil the whole thing, but yeah.
Well, really. Do any of the panelists have any comment to make? Yeah. Oh, yeah. Dr. Satya.
Okay, couple of questions. One was about virtual reality perimetry. So there are so many companies now who are making those devices, and they come to your clinic and they give it to you for a trial, and then you can use it for a month or two. We also did that. How good is it? One. And second, do you think you presented so many kinetic perimetry pictures? Do you think that virtual reality perimetry, which is based on kinetic perimetry, would be better than static perimetry?
I think it's a bit hard to tell now, because they're just, as you say, bringing it around to our clinics to let us try, and we haven't really done a whole lot of head-to-head. I mean, they claim they've done a lot of head-to-head comparisons. I think for the static perimetry, those that I have encountered, they seem to do all right. For kinetic perimetry, I must confess not to have explored how good they are at kinetic perimetry, but presumably they will work just as well, because kinetic perimetry is probably a lot more forgiving in terms of how it's done, and these virtual reality headsets, they just do it, allow it to be done in a more standardized manner, just like the kinetic perimetry on Octopus or on the Humphrey. So it's likely that they will do okay, but I must say I haven't bought a set myself to try out yet.
I know. One of the things where the kinetic, of course, was doing well is also to give us the full field, which I'm not so sure what virtual perimeters, to what angle they would be able to do, considering that their screens are smaller, though they're probably going to get at least 60 degrees plus. But in the kinetic, I think we go right up to 90 and even beyond, right? So that's. Yeah, those are different. Yeah.
I think in neurological patient it's helpful, Goldman, because I've seen some of the neurologists still using Goldman perimetry because their attention span is less, I think that must be the one reason.
Indeed. So now invite Dr. Naresh Montwani to speak on his talk on a deceptive, looking at the bigger picture on a deceptive basis.
Good morning, everybody. Good morning, everybody. How are you guys? So I was given this topic to be followed, to follow the glaucoma and papilledema. I've been told now that I need to talk first. So there might be few references which I know are in their talks, but we'll go with it. Please don't hesitate to ask if there's something that is missing, because the whole idea here is practical approach to the patient. That's what the session is about. So I would rather do 5 slides and help one of you to take 1 point home, so that you can do practically, you can apply it to the patient rather than me going through the presentation. So the topic I was given was deceptive disc, looking at the bigger picture. A bit difficult to decipher, but because it is deceptive, so let's start with the deceptive bit of it. I'm practicing presently in UK, so my talk might have a few of history bits in it, but of course too much of science can be boring also. I still feel that clinical skills are probably the most important despite all the technology. Digvijay might, being the younger ophthalmologist, might talk of AI and all these technologies, but they can only be as good as the person who is looking at the visual fields, looking at the disc. So it's something where I feel the patient and doctor interaction is a must. There are talks about you don't need to see glaucoma patients, you don't need to see. I probably differ, but I wanted to ask a question to Digvijay in one of his AI sessions, but I never did. It's something like you want foundation, then you can have a small or a big house, but you want a foundation which is good. Coming back to deceptive disc, what is disc? If I look into the definition of disc, it is a flat, thin, circular object. But my previous speakers were supposed to talk about excavated discs and raised discs, papilledema, and is it glaucoma or neurological. So, well, they've not spoken, so there will be a few things that you have to remember this talk and then put it after their talk. We also think the disc as intervertebral disc, the disc as floppy disc. So it is confusing, it is deceptive, the word disc itself. I'm reminded of this Prof. Harry. He was the pioneer for the disc, and any talk about optic disc without mentioning him, I think, is incomplete. He had articles written about him in IGO when he was alive, and then in American Academy of Ophthalmologists when he passed away. Just a few fun facts. How many of you have done your graduation MBBS from 2 colleges? He had. It was circumstantial. 1946 he started in Lahore, there was partition, and then he moved to Amritsar. Fun facts. Fun facts. He does not have any degree for America, but he worked last 50 years in America. Fun fact, the very first time, he was not even in ophthalmology, he started his research in optic disc and carried on from there. So yes, so he called it optic nerve head, which is what I also like to call, but again, it's just a matter of nomenclature. The next part of deceptive disc, looking at the bigger picture, I just wanted to highlight what all things are we looking. So I've kept the abnormalities aside, and even if first thing is anatomy, then is pathology. So I'm sorry that for some doyens here, it's very, very basic, but then it was supposed to follow after the high-tech talks. So with all these points, which are not really anything to kind of talk about, we have to identify the disc margin first, and after that we need to see where the neural rim is, what we call as cup disc ratio. Yes? Nobody's okay. Good morning, everybody. Somebody wake up, yeah? Okay. So the technique is very important. Light in the room has to be ambient, thin beam, use the slit lamp for its slit, and focus if possible with the dilated pupil. I know people have less and less time, but at least the initial evaluation, and then document. The thing is, we can use lots of techniques. We can use the technology bit, which is disc photos, HRA, SLO, blah, 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 and we can use various lenses. But one thing you have to remember, size does matter. there's a magnification factor, there's a correction factor for each lens. And would you believe it if I told you that 290Ds of two companies have different correction factor? Okay, so when you are checking the size of the disc, at least in the first go, and then you can check the size of the cup on every occasion if you are looking for progression, etc. You need to make sure that you're using either the same lens or you're putting in the correction factor as well. The asymmetry, I don't know which one is normal. Can anybody point to which one is normal? Anybody? Both are normal. The left one, the scleral canal is slightly bigger, and hence the total, we as a convention, we use vertical diameter. So in the left eye, we can see, because the size of the disc is larger, the size of the cup is larger, CD is different, and this patient can be or should be at least followed up to rule out or establish progression. There are various normals. I don't know what is normal, but I call it average, I call it typical. And the appearance will not only be dictated by the scleral canal, it will be dictated by how the nerve comes and attaches itself to the eye. And what I as a clinician want to know is, number one, is it a pathology or not? And number two, is the pathology treatable or not? Because there's no point of, just highlighted by Prof. Tam, that there's a patient who was treated for glaucoma, operated for glaucoma, and then I don't want any of my trainees or any of my patients to go through that, but it happens. Despite everything, this happens. So let's try and hold on to, this is a case which was very close to my heart, because this patient had seen 3 consultants previously. Can you see what is there? It had a visual field defect which was corresponding to the optic disc appearance, and the patient had a family history of glaucoma. But then this is not glaucoma, this is optic disc pit. If you use the technology only and not see the patient, it fits. There's a visual field defect on superior thing, and can you see there's a macular schisis also next to the disc? There is a defect, but this is not glaucoma. We don't need to operate on the patient, do TRABs, and then realize. Again, call me an old school, but that's what it is. The last bit, looking at the bigger picture. There was this study, BEEP, Bridlington Eye Assessment Protocol Program, one of those names, so BEAP, and they looked at about 10,000 plus normal individuals. It was an epidemiology, it was an epidemiological study, it was not patients. And what they found was that normal distribution of the disc size and hence the area was as varied as 1 to 3 square millimeter. Now 1 to 3 square millimeter might not sound very much, but if you look at the percentage, you are talking about 200%. That's a lot of percentage points. And there was some which even came up to 6 square millimeter. Okay, so this was supposed to be another histogram for disc asymmetry, where what they did was right side CD ratio minus left side CD ratio, and that was put on the graph. They saw that 85% were within minus 0.2 and plus 0.2. But there were 15% in the 10,000 patient group or individual group who did not have any problem, who did not have any pathology, but they were still outside that. So disc asymmetry also. So looking at the bigger picture, we know it's not unusual. So yes, we need to find the pathology, and we need to pick up the battles that we can fight.
Yes. Thank you, Dr. Naresh, for for kind of bringing us back to the foundation.
B2B.
B2B, and to look at it as well. I mean, obviously, the thing to realize is that, you know, all these classifications of normal, abnormal are something that we have gotten, not that
Exactly.
nature has got it in. So it is a continuum or a spectrum
Yes.
that we kind of, you know, as humans like to classify in our intelligence. And
I
this is now
remind-
what we are pushing to the AI. As you
Well, I
probably
mean,
saw in that,
yes,
but
AI is very good provided we look at it. Even the simple thing of HRAs, SLOs, the computer decides which layer where, and it projects a red and yellow and green. But unfortunately, I mean, we never, at least most of my colleagues never look at where it has plotted. Oh, it was yellow, it is red, now it is progressive. No, look at, because you need to understand how the machine works, where it is plotting, and how is it giving those, what is that called, false pseudo colors.
right.
But then, yeah, I mean, I might be old school, but I'll be learning from you, Digvij.
And I think coming to colors itself, I think as you discussed, that itself can be deceptive in terms of the real natural colors. You know, what may
Yes.
appear pale to one may not be pale at all.
No,
It could
for
be
example,
myopic or
Heidelberg, it gives pseudo colors.
yeah, those are, of course, it's putting them on top. Yeah, very good.
Thank you very much.
Yeah, so the OCT, especially the swept source OCT and the EDI OCT, where you're not, the computer is not marking anything. I mean, like, we don't have any objective data. It's the morphology, the disc morphology. To especially pick up the congenital anomalies, I think the swept source OCT and the EDI OCT, you can look at a lot of things, and the automatic segmentation there cannot get you wrong. The like things like drusen and all, you can directly visualize them for pseudopapilledema. Now I think in the other hall Stefan would have given his talk about it. So there is, like, it's there, you can see it, you should know how to pick it up. So for pseudopapilledema, drusens can be seen. Similarly, hypoplastic discs, you can see the canal size. I mean, like, objectively you get it, the data there. If it's a small thing, and pit you've shown, pit is like, you know, you can directly, if you have any kind of confusion, the OCT, you can, the technician can directly. So for the congenital optic disc anomalies, where the you can have a deceptive appearance, OCT has a definite role, I would say.
I mean, I completely agree that OCT and everything has its role, but till I saw that patient, we use UBM. That was a UBM picture. OCT, whatever, the high density one. But what I'm trying to say is, you are correct, but one has to suspect. I see what mine knows.
Right. Thank you.
Yeah,
Thanks, sir.
definitely. Thanks.
I now invite Dr. Naveen Jayakumar, sir, our president of AIOS, to
I'll
to
finish
take his talk. Now we'll shift from deceptive discs to deceptive diplopias or dazzling diplopias. So over to you, sir, and then we'll come to Dr. Rohit, who's
Yeah.
just joined in. Yeah.
We'll wait for Rohit to catch his breath. He must come running from some other room. Good morning to all of you. My talk is 8 minutes, approach to a patient with diplopia. So I just thought I'd be very, very brief and put out a couple of, this is the way I do it personally, so things may vary. So I'm going to divide this into a couple of things. So one is history in general, and specifically history about the nature of the diplopia. The second part is more about the examination, the ocular motility, the lids, pupil, and don't forget there are other structures around like the orbit, paranasal sinus, and of course the CNS itself. Number 6 is of course the imaging, and last is how do you manage the diplopia. So let me just go through the history quickly. Apart from the diplopia, please remember, depending on how patients present to you, whether it's in a ward or in your office, are there any focal neurological deficits? What about general things like cognition, things like headache, etc., which you need to keep in mind? Pain is very important. The presence of pain with diplopia, whether it's a periorbital pain or a periocular pain, the presence of headache, what kind of headache it is. Orbit and PNS, generally we forget about it, but please do remember it. Orbit signs may not be very prominent, they may be subtle, but it's up to us to pick it up. And of course, general factors like risk factors like diabetes, hypertension, hypercholesterolemia, etc. But apart from that, giant cell arteritis is something you need to remember. And my nightmare, my scary thing is uncontrolled diabetes in the presence of cranial nerve palsy. Is it mucormycosis, for example, which can be very fatal. Secondly, about the specific nature of the diplopia, I think if you ask even these questions and elicit patient answers to these, you will probably even end up diagnosing which muscle is involved. So if it's monocular or binocular, that will tell you whether the cause is intraocular or extraocular motility related. Are the images separated horizontal or vertically, which tells you what kind of muscles are involved. Which direction is it worse? If it's on left gaze, it's about the muscles relating to left gaze. If it's a divergence is more than convergence, then you're thinking of a sixth nerve palsy. Is the diplopia crossed or uncrossed, which will tell you whether the eye is exo or eso, because these may sometimes be very apparent to you, but sometimes they may be subtle. So asking these questions and doing the simple things is very helpful. And of course, last but not the least, is it variable? So everyone knows about myasthenia gravis, but thyroid ophthalmopathy can also present with variable diplopia. Right, then we go on to our examination and we are looking at our ocular motility, and just to be brief, this is the things I am looking for. 3, 4 and 6, is it isolated or combined, multiple cranial nerve palsy? Look at the pupil, are you looking, is it anisochoric, etc.? Are you looking at a third nerve palsy, or the presence of Horner syndrome is also important to us. The other cranial nerves apart from 3, 4 and 6, which could be the optic nerve, the 5th, the 7th and the 8th. So this entire constellation from 2 to 8 will also help us in helping with the diagnosis. And of course, please remember there are supranuclear patterns which one can also pick up. So very quickly, third nerve, I think everyone has seen. Fourth nerve, here is this kid with a left hypertropia, and you do the 3-step test. And you can see that the hypertropia is worse on the right gaze, and it is also going to be worse on the left head tilt. So here is the right head tilt, which is fine. The left head tilt shows that upshoot, telling us this that this is a superior oblique palsy on the left side. Okay. However, this kind of movement you cannot do if there is a presence of a third nerve palsy as well. So how do we make out fourth nerve palsy in a third nerve palsy patient? So you can't look at the depressing effect of the superior oblique. We look at the intorting effect. This is a patient who has had a peribulbar block and all the recti are kind of blocked. So here very clearly you can see the intorting effect of the superior oblique. When she looks down, here you can see that very clearly. This is the kind of movement we need you to see in the eye kept in the abducted position. Ask the patient to look from up to down and look for this intorting effect, and that will tell you whether the fourth nerve is intact or not in a third nerve palsy. Please also remember restrictive palsies, variability as in myasthenia or TED, orbital fractures, myopathies, and occasionally Duane's type 1 can also produce a little bit of diplopia as well. The saccadic speed is also important. This is a lady who had a right third nerve palsy with ptosis. Her fourth nerve was also affected. But here I want you to see the abduction in the right eye. And if you see it in slow motion, it's even clearer. You see how quickly the left eye adducts and the right eye is still moving so gradually. This is a slow saccade, an abduction saccade, which is significant because it tells you that the sixth nerve is also affected. Lids and pupil, as far as lids are concerned, is there ptosis or lid retraction, the presence of fatigue sign, and of course lid gaze dyskinesias. Here we are holding up the lid and looking at it, and sometimes when you do this, you can actually miss a couple of things. So here's what you can miss. So look at the lid there. When she looks down, the lid retracts. Okay, the left lid retracts. There you go. The left lid also retracts when she looks inwards. Okay, an adduction, you can see that. So this is an aberrant regeneration of the third nerve. It can happen in trauma and compressive lesions, but definitely not in an ischemic nerve palsy. The other picture shows you the pupil. Look for anisocoria. Here is a patient who had trauma. The right pupil is there for your just for visualization. See the size of the left pupil between adduction and abduction, and you can see this constriction when the eye is adducting. So this is a pupil gaze dyskinesia. So that's also significant. Orbit PNS and central nervous system. So please remember, uncontrolled diabetes mellitus in cranial nerve palsy. Do not forget the possibility of mucor. Imaging, everyone knows MRI with MR angiography is important. I would definitely do it for any case of third nerve palsy or isolated sixth nerve palsy. Fourth nerve, depending on the history, I reserve my judgment there. Obviously, any case with multiple cranial nerve palsies or dyskinesias, any patient with a cranial nerve palsy with CNS involvement or Horner's or orbital signs as well. Okay, so that's a patient with dissection there, carotid dissection with neck manipulation. Management is very quickly, so I'm not going to waste too much time on this. My time is running out. But importantly, I want to talk about dangerous diplopias. So in a pupil involved third nerve palsy, we'll be looking at aneurysms. As far as painful ophthalmoplegia with orbit signs, we could think of Tolosa-Hunt or mucormycosis. Multiple cranial nerve palsies, neuropathies, think of orbit, cavernous sinus, and the skull base. If you have a cranial nerve palsy with either lid or pupil or eye movement, then you can think about, is it Horner's? If it's with a small pupil, but if it's with a big pupil with ptosis, it could be aneurysm. Variability, you know, myasthenia gravis. Don't forget that myasthenia can have serious generalized issues as well, including respiratory issues as well. And any new onset headache, scalp tenderness, pain or swallowing, not only aneurysm, but you can also think of temporal arteritis. So with that, I'll just close and we can open for discussion.
Thank you, sir. Any comment that you would like to?
Excellent talk, and I think right now where Indian neuroophthalmology is there, neuroimaging in cranial nerve palsies, as even Sir said, especially third cranial nerve palsy and sixth nerve palsy, it's kind of becoming a must because of the a few horror story cases that he shared, especially in diabetics. Especially in diabetics.
Yeah, I think one should always make an attempt to, you know.
Fourth nerve, you said that you will reserve your this thing. I think it's in trauma.
Because fourth nerve is usually, it could be a congenital or sometimes it's a post-traumatic fourth nerve. And congenital can happen in much later in life because of a decompensation of a foria. So there are ways you can diagnose that, look at old photographs, etc. So, and in diabetics, I generally prefer to follow them up, but please remember, whichever cranial nerve palsy you're following up and not doing an imaging, it's good to follow them up very frequently in case untoward other cranial nerves start getting involved or there's something is getting worse, then you know you're not dealing with a diabetic fourth nerve palsy, it's something else. Right. And I think it's important to keep that in mind if you're not imaging at the outset. And I think MRI with MRA is useful. In fact, I had a word with our radiologist. I said, what about if it's too expensive? Can we at least just do a CT angio? Will that be less expensive? And she actually said it's not really, it's almost the same cost. So I think between the two, we might as well do, and it's you don't need to worry about injecting contrast and things like that. So I think just doing an MRI with A would be the best thing.
Right. Thank you. So we move from the yes.
The MR, I think there are radiologists who just do cranial, who just do CNS, the neuroradiologists. One needs to have a good communication with them, because unless you tell them what to look for, they might miss it. They might be very subtle lesions, and it's not the fault of radiologists. Again, it comes back to I see what mine knows. So if you're looking for it, you might find it, which otherwise can be missed.
Right. So we now move from the third, fourth, sixth nerves to the second nerve again, and I invite Professor Rohit Saxena, the Secretary of AIOS, will be presenting his talk on disc edema, approach to a case with disc edema.
Thank you, Digvijay, and of course, thank you for the opportunity. Can I have a pointer, please? Pointer, if possible. So, disc edemas has so much to tell, so little time, so I'll just try and run through whatever. Key approach, at least that's the way I would work up, is firstly identify whether it's bilateral or unilateral, because the causes tend to be different. Of course, for unilateral, the other important thing to know is whether what's the status of the other eye. So other eye could be normal, there could be edema, or it could be atrophy. So all these things are important to know. In fact, the dictum goes that if there is poor vision in one eye, you actually need to worry about and more extensively evaluate what you believe is the normal eye. So bilateral, you're looking at pseudopapillodemas, papillodemas, hypertensive retinopathies, bilateral papillitis, compressive neuropathies, which more often than not require more systemic and neurological workup. You have unilateral edema, you have hyperemic eye, you have more of inflammations, demyelinating, pseudopapillodemas. You have a pale disc, there is a pale edema, there is a possibility that's ischemic in origin. And if you have optic atrophy, either it's tumor you're worried about, or else the event that's happening in this side today happened in the other eye some time back. So key important thing, you have bilateral disc edema, you need to look for papilledema versus pseudopapilledema. You need to be sure whether it's true or just appears to be edematous. So the key signs would be obscuration of vessels, clear edema. So a lot of times small children with hyperopic discs are referred, extensively investigated, LP is done, repeated imaging is being done, and they just have hyperopic discs with mildly blurred margins. So you need to be very careful. The cup is obscured, the vessels have to be obscured, and whenever in doubt, follow up the child after a week or so. If it's progressing, you are going to start seeing an increase in the blurriness, you're going to see an increase in the obscurations. So you can classically see the difference that is there. So while it appears to be edematous, you can see that the margins don't seem to be sharp, but there is an absence of cup. You can see the vessels are pretty clearly visible there. So no hemorrhages, exudates. So that's your first important thing. And anyway, most important thing, please remember, whenever you're assessing the disc, do it in 3D. Always do a 90D assessment of the optic nerve head, never with a direct ophthalmoscope, and definitely not what the retina people are very fond of, the indirect ophthalmoscope. So these are like, 4 key conditions that you would see. So this is pseudopapilledema. You can see the vessel, the margins are blurred. It does look as if there is a bump or a lift here somewhere, but the vessels look pretty good. Here you can see, of course, you have a lot of exudates, you have hemorrhages, splinter hemorrhages here, but the blurred margins, the absence of cup, but the obscuration of vessels. Here you can see the edema, the splinter hemorrhages, they are far away from the disc. So there is no continuous area, there is a normal retina in between. Whereas here you will see, even thus far, you have a retina that is affected. So all this is arising from the disc. Here, this is not completely involved. In this figure, you can see the hemorrhages are away. You have a relatively normal-looking retina in the middle. So this is hypertensive retinopathy. And again, here you can see a lumpy, bumpy disc. Classically, you'll see, of course, on ultrasound or an X-ray, you'll see this calcification here. But you can see the lumpy bumpiness of the disc. It's not looking like clear edema, but there is irregularity of the margin. The vessels seem to be bumping up over the drusen's that are there. But so if you are sure it's true papilledema, obviously patients is going to have signs suggestive of raised intracranial pressure for that would include nausea, vomiting, headache, usually bilateral, although they may be asymmetrical sometimes. And of course, fields may show initially just enlargement of the blind spot and a bit of constriction of the fields, but over time you may have all kinds of field effects as the optic nerve starts getting affected. Imaging is very, very important at the first go because you need to rule out space occupying lesions. And of course, if you have an IIH as a suspicion, you must do an MRV because venous sinus thrombosis needs a little more aggressive and a little more different kind of management. So investigate for raised intracranial pressures. First, rule out a space occupying lesion. Check for pressures. Check for sometimes even low grade meningitis can present like raised ICT. Of course, you need to work with your neurologist when you're doing this. Weight loss, as a thesis under Dr. Swati showed, while one of the most challenging things to achieve in life, is definitely very impactful when you are managing IIH. And of course, all the other things, look for drugs that the patient may be having, controlled blood pressure, anemia, CPAP for obstructive sleep apnea, diuretics, but our sheet anchor remains acetazolamide. Surgical options are there. We do optic nerve sheath fenestration if the vision is significantly affected. When you're looking at unilateral, I won't go through all the diseases per se separately, but usually an initial hyperemic appearance would be more of papillitis, sometimes even asymmetric papilledema when the one eye gets involved and the other eye is still waiting to show its effect. Pale disc edema, you would at the very onset start thinking of ischemic optic neuropathies. Thankfully, we tend to see much less arthritic causes of ischemic optic neuropathies, but still that is something that you need to keep in mind. Optic neuritis has been discussed frequently in multiple forums in this conference, so just remember typical and atypical features. You need to now work up more extensively. Imaging has now become one of the sheet anchors for diagnosing and managing and trying to classify the reason behind it. Role of IV steroids, almost now upfront. The moment you think optic neuritis, IVMP is now a treatment that you must think of, even if the vision may be moderately affected, or else especially in view of the fact that the patient may have NMO or MOG, the outcome especially of NMA deteriorates significantly if you delay IVMP. And of course, if there's an atypical presentation, you must think of getting serology for NMO and MOG. Availability, of course, being a challenge in India. When it's ischemic, you think of NAION or arthritic. It's important to distinguish or identify arthritic very, very quickly, because it's almost like an emergency. You need to treat very, very fast. Unfortunately, currently a lot of overlap between NMO, which presents late, and ischemic optic neuropathies is occurring, and that's why sometimes we have to be more aggressive whenever we look at unilateral disc edema with severe visual loss and in a middle-aged or a little older patient, because it still could be a late presentation of NMO, but essentially a little older age group with the presence of systemic side effects, ischemic optic neuropathy becomes one of your key thoughts that you have. Again, the effect and the involvement can be very subtle. You can see the patient had not exactly very significant vision loss, but just a mild pallor, and there was a central ischemic neuropathy that was there. So identify all sort of risk factors. There are a lot of risk factors that need to go. Sleep apnea syndrome, often missed. You need to ask the wife whether the person snores or not, and does she get a good sleep or not. So there is a whole lot of questions you need to ask when you're managing NAION, and unfortunately, till now, there is no clear intervention management options available, the most important only being control of risk factors. As I mentioned, arthritic, important because you need to confirm arthritic, consider GCA, because that requires emergency treatment. This is one of those rare conditions in ophthalmology where 5-year survival rates are discussed. So if you don't treat, or if you don't manage or intervene quickly in GCA, you can have not only the other eye involved, but also the effect happening in multiple other parts of the body and causing an effect. So like I mentioned, arthritic AION is an emergency that you need to manage and require high dose steroids over a long term, sometimes continue up to 1 to 2 years, and you may titrate with the ESR CRP. So just coming back again, it's important. Systemic workup of bilateral, unilateral, you may be misled by an asymmetric presentation. Otherwise, look for other causes. Thank you very much.
Any comments from the panel in the meanwhile, while we call up the next speaker?
Yeah, so
Dr.
as
Ashwin Gandhi would be speaking next on differentiating glaucomatous and non-glaucomatous optic neuropathy, and Dr. Tham, I'd also like you to weigh in at the end of that talk. Yeah.
Yeah, no, I was just saying that whatever Dr. Rohit presented, if I could summarize it into 2-3 lines, a colorful optic disc that has sort of hemorrhages and pallid edema, or with or without exudation, usually is either ischemic optic neuropathy, neuroretinitis. On the other hand, optic neuritis, NMO, all these are just subtle disc edema, or sometimes in retrobulbar optic neuritis, no disc edema. So, and bilateral disc edema is papilledema. Many times we get notes where single optic disc edema, because of all these causes, is written as papilledema. Papilledema is always because of the raised ICP. Yeah.
And one should also remember that a very angry looking disc or a massive disc edema one should think of infiltrative optic neuropathy, which is not that common, but it can be fatal. Yeah, thank you. So my talk is going to be differentiating between glaucoma and neurological cause of optic neuropathy. As you said, as we know that glaucoma is the commonest cause of optic neuropathy, and I'm going to do that by having some cases. A 46-year-old male, this is a representative case with a gradual loss of vision in both the eyes. He has been on treatment for primary open glaucoma. Visual acuity is 612 and 69. Intraocular pressures are borderline, and he has open angles. So are there any red flags here with a 46-year-old male with loss of vision? Well, the red flag here is the age. Anybody who is under the age of 50 and has a significant cupping, unless you know why that patient has developed glaucoma, you should be looking for neurological cause. I'm not saying that glaucoma cannot start below the age of 50, but if you have a patient, young patient who has a reduction of vision, and if it's not fitting in glaucoma, you should be looking for a neurological cause. This is the picture of the optic disc. Now, second case scenario. So that was age. Second red flag, a 56-year-old female with a gradual loss of vision in both the eyes. Visual acuity is 2/60 in the right eye, 6/36 in the left eye. What is the red flag here? The red flag is profound visual impairment. Glaucoma on its own in the early stage of the disease is not likely to present with visual impairment. It can happen much later in the disease. So these are some of the studies which proved that Jonathan Trope found that 12 patients with a compressive optic neuropathy had a loss of central vision as obviously as a presenting feature. While Greenfield et al. Found that visual acuity less than 20/40 should 77% in his series had cupping which was non-glaucomatous. One more case scenario. So one was age, second was visual impairment. Now we have the 70-year-old male with the visual acuity of 1/60 in the affected eye. And here the red flag is the NRR. While the patient does have a large cup in the left eye, the affected eye, but if you look at the neuroretinal rim, and there is an arrow here, that is pale. Now that's again not a feature of a cupping of this size. So patient with a large cupping, if it's because of glaucoma, the neuroretinal rim will continue to remain pink till very late in the disease. So the red flag in that case would be pale neuroretinal rim. Now what do we do next? How do we confirm? Now we already are suspecting in cases like this where you have a pale neuroretinal rim, a large cup, and you feel that, oh, this may be a non-glaucomatous cupping. How do we confirm? What do we do next? Pupil for RAPD would be a very objective test which will confirm if it's a non-glaucomatous or a neurological optic neuropathy. So the question is, of course, can glaucoma also have RAPD? For glaucomatous cupping or for glaucoma to have an RAPD, there has to be a difference of more than 0.43 in the cupping. That means the neuronal loss in both the eyes is so asymmetrical that the RAPD can be because of glaucoma. The other two signs which can help you to differentiate between glaucoma and neurological disease would be color vision. Remember, glaucoma is primarily an optic neuropathy which affects arcuate fibers first. While if there are signs of papillomacular bundle affection, that does not happen in glaucoma, not at least early in the disease. If patient who has been diagnosed as having glaucoma, not a very advanced glaucoma, has a color vision deficiency which cannot be accounted for by other causes, you probably are looking at a non-glaucomatous optic neuropathy. The other pointer can be in your visual fields. If you have a foveal threshold available, and if you have a reduction of foveal threshold early in the disease in cases of glaucoma, you know that maybe you are looking at a non-glaucomatous cupping. So RAPD, color vision deficiency and foveal threshold will point towards effect on a papillomacular bundle, which generally would be spared in glaucoma at least early in the disease. So this is one of the study which can we look at the optic disc and differentiate between glaucoma and compression? Well, optic disc hemorrhage, presence of hemorrhage was specific for glaucoma. Family history of glaucoma, 96% of the patient, you say that okay, that patient is likely to have a glaucomatous optic atrophy, versus pallor of the neuroretinal rim, which will go more towards a non-glaucomatous cupping. What we are worried about, of course, is a compressive optic neuropathy. Let's look at one more scenario, one more red flag. So we looked at the age, pupil, color vision, appearance of the optic nerve. Now this is a case of normal tension glaucoma with a normal visual acuity. The pressures are 16. Patient has minimal blurring of the vision. The cup are shown here. There is a large cupping. There is no real notching or vertical elongation, which is very apparent here. However, when you do the visual fields, obviously because the confirmation of glaucoma would be by appearance, the intraocular pressure, appearance of optic nerve, and the visual fields. If you do a visual fields and if you find a field defect like this, where you see in the left eye, the predominant defect is mainly on the temporal side, which again is not really very typical of glaucoma. Glaucoma typically would start on a nasal side, nasal step, and it will break into an arcuate scotoma. While if you have a predominant temporal defect, you know that you are probably dealing with a neurological cause of cupping or an optic neuropathy. So the next red flag would be a visual field which is not corresponding to the appearance of the optic disc. If they are not matching, you know that you are dealing with non-glaucomatous cupping. So what if the normal tension glaucoma by itself has become a little controversial entity? Do we really have a disease entity like that? So there was a debate to say that can we now just do neuroimaging everybody whom we diagnosed as having normal tension glaucoma? And one study found that 3.8% of the patients who were referred for evaluation of normal tension glaucoma actually had compressive lesion, and normal tension glaucoma was a red herring. Versus there was another study where they said, well, not really. Everybody who was diagnosed as having NTG were having NTG. Obviously, debate probably will veer more towards logistics and financial reasons rather than a scientific reason. This was a very nice study which was done by our colleagues at Shankar Netralaya, by Dr. Ronnie George and Nikhil Chaudhary. They looked at 6 patients who were being treated as patients with glaucoma, and they turned out to be neurological issues, and they went back to the chart and said that, oh, what were missed out, and what was missed out was really startling. Right from the beginning, they said that 4 out of 6 patients, the treating physician failed to attend to grossly asymmetrical vision loss. The morphology of pupil, which is in all 6 patients, that was missed. So if a swinging flashlight test was done, probably they would have found an RAPD and would have treated the patient differently. Failure to document optic disc morphology just beside vertical cup disc ratios. There was no mention of the appearance of neuroretinal rim. Failure to correlate visual acuity with the cupping of the disc, or in fact, shockingly, half of these patients never had a visual field. So a borderline pressure, large cup, and the glaucoma diagnosis was made. So these were the mistakes which, if you avoid, then it's not really difficult to differentiate between glaucoma and neurological disease. So who would really need a neuroimaging if you are treating a patient with glaucoma? Presence of headache or any other neurological symptom, obviously you would look for neurological cause of glaucoma. Decreased vision, fluctuating vision, a vision loss, which is, I'll take half a minute. Atypical visual field for glaucoma, like visual field which respects the vertical meridian, which is predominantly central or temporal. Atypical rate of progression of vision field loss, because glaucoma is not really, it's very rare for glaucoma, unless it's a narrow angle glaucoma, it's very rare for glaucoma to present with an acute event or a very rapidly progressive event. When pallor is more than cupping, or there is an asymmetrical cupping which cannot be accounted for by the general examination. Thank you.
Thank you, Dr. Ashwin. Again, one of those areas in ophthalmology, neuro-ophthalmology and glaucoma practices both, which kind of always tend to overlap. And I think if you actually think of it, in a way, a lot of this, it's the same part of the eye getting affected, though the mechanisms are possibly very different. And that's why anything that you would like to add, Dr. Clementham, for this, your talk also was somewhat bordering on glaucomatous and neuro-ophthalmic fields, and in your own clinical practice.
I think Rashmin has covered largely all the pointers. I would say that the best thing you can have is an open-minded glaucomatologist.
Yeah.
Because you got to convince them sometimes to accept the fact that the patients need to be investigated a lot more. I think the big challenge is the normal tension glaucoma group, because they have normal pressures, and now you see the literature come out from Japan and South Korea that they have 80-90% of their glaucoma is normal tension glaucoma. I find that really difficult to to even process that really we are going to be having such a big epidemic of glaucoma. I think perhaps the one thing just to highlight from Rashmin's talk is the fact about progression. Because if normal tension glaucoma, you're really not expecting very much progression. In fact, the CNGTS, the Collaborative Normal Tension Glaucoma Study, some of those, they really only had a defect 5 years later for them to be called NTG. So it really depends whether you want to bombard everybody with drops right from the word go, or you just want to patiently wait for 5 years. Neuro-ophthalmologists are patient people.
Dr. Motwane had some.
Dr. Ambik?
That's very correct. I mean, it's open-minded glaucomatologist is probably the word, and that's why we need to. And the other thing which I wanted to say to Rohit as well as yourself is there can be dual pathologies. So you might be able to see the pseudodrusen, but you don't want to miss the early papilledema in a optic disc drusen case. You might have glaucoma, but there could be something neurological. So you have to be a clinician before relying on the technology.
Especially many a times, especially with NTGs, because all these patients are generally elderly and have all those risk factors which make them susceptible to ischemic optic neuropathies also. So many of these patients may have glaucoma and may then develop some optic neuropathy, ischemic optic neuropathy, which is really very difficult to differentiate. I still don't know how we can go about it. So if there are any thoughts on it.
I guess a lot depends on resources that are available. But patience doesn't cost a whole lot of money. And if you have the resources to do very regular follow-up with the visual fields, then if it progresses, it probably is glaucoma, assuming your neuroimaging is normal. If it progresses very fast, then you're going to need to neuroimage them for sure. So it's just watching the pathophysiology and seeing whether it goes in that way. At least that's what we know for now, until we can get more definitive answers. I mean, there's possibly some things coming out from electrophysiology, but I think the jury is still out on that one, and we probably have to wait for more information to come out before we can be more definitive about whether electrophysiology will help us. But in our group where we did look at some of the electrophysiology, about 13 to 14% had a retinal abnormality instead. So it really just, but again, it's a slightly select group because those were patients referred to us by glaucoma people who may be a bit more open-minded and they suspected their own diagnosis, and they said, please check for me, and so that was helpful.
So Dr. Ambika, how often do you see that overlap?
I'm sorry, I was stuck in another session. I don't know what is the discussion going about.
How often do you see?
The glaucoma patients seeing the neuro-ophthalmic patients and realizing it's something else versus the other way around?
The amount of positivity of glaucoma referrals to be turning out to be neuro-ophthalmic. See, yes. I think whenever the glaucoma people are going to refer, it's a long-term, intraocular pressure is well under control, fields are worsening. It all depends on what type of fields worsening and how soon it is worsening and how the disc is. So if the disc is not correlating with the visual fields, the age and all these will matter. If I'm going to get a young person who is having a progressive visual field deficit in spite of a good control, well, that's not a candidate what I will watch. If it's going to be an elderly patient who is having all the investigations done for one of his, whatever systemic evaluations, these patients, apart from imaging, I may ask for a carotid Doppler and other investigations to rule out a vascular and a space occupying lesions and all those. I think many a times it turns to be positive, but we have a lot of other causes also which can cause an advanced visual field, like what Dr. Clement had said, that myopic peripapillary changes and macular changes and a lot of other unexplained retinopathies which can also start. And if the patient is 60 plus and you're having a progressive visual deficit, we may have some neurodegenerative causes also to be add on. because many a times Parkinson's, dementia, AD are underdiagnosed in our population, and they also can cause this sort of progressive visual deficit.
Yeah, there also has been, old thought that appearance of disc, the cupping also can give you a clue. If there is a saucerization of blood vessels, maybe it's an ischemic event which is causing a cupping. But I don't know how far that's been proven.
Yeah. There's always a tiff whether pallor more than cupping or cupping more than pallor.
And glaucoma specialists, usually if you give this talk to a glaucoma specialist, I remember somebody, Ronnie, giving this talk. So his talk started with that ISNT rule. I mean, like they focus at, they really look at, I mean, like we should all look at the rim. The inferior is thickest and then the superior and then nasal and temporal. If it isn't following that, then, you know, they send it to us.
And one more risk factor in these patients is OSA. Obstructive sleep apnea is quite high, and that can worsen a glaucoma as well as an optic neuropathy. Yeah. So maybe we have to add that.
So that brings us to what is the workup for NTG usually, Clement? Or what do you, I mean, like, what is other than neuroimaging?
So other than neuroimaging, I think now we all have to do the macular GCIPL. I think that will be really important. Besides the RNFL, in glaucoma they ought to match the rim loss, the retinal nerve fiber layer at the rim, and the macular GCIPL ought really to match. If it doesn't match, we have a problem. Autofluorescence, a macular OCT, a plain macular OCT to make sure you're not missing anything, looking at the EZ line and all those, looking for a maculopathy. And then actually I think probably the best test is just serial follow-up of these NTG patients, you know, just holding off the medicine for a while and say, well, how much is this going to progress? And if it does progress, you probably won't lose too many pixels before you reinstate treatment if you can get them to do, you know, even 6 monthly follow-up.
Dr. Ashwin, you have made a very good and clear and comprehensive picture on comparing the glaucomatous and the neuro-ophthalmological appearance of the optic disc. Especially when you talk about the myopia, you know, sometimes we have a case where it's a case of high myopia. They may develop a neurological as well as glaucoma cases, you know. So what are the red flags that we should look for? What it is sometimes difficult to diagnose glaucoma in high myopic patients. There are so many problems. So also is a problem with the neuro-ophthalmology, neuro disorders as well. So what are the important things when you are seeing a patient who has either a neurological disorder or has a glaucoma?
So I would start with neurological disorders. So myopia may have issues, but it will never, especially if it's a unilateral myopia or a problem, would not have other optic nerve dysfunctions like RAPD or color vision deficiency. Visual field defect can be seen in if the disc is really abnormal, but if tilted disc is one of the differential of bitemporal hemianopia. But if there is no progression and if it's been adequately worked up, then you can blame it on the pre-existing problem. If there is a progression, fast progression, optic nerve dysfunction, you know that you're dealing with a neuro-ophthalmic evaluation. Now myopia glaucoma, of course, is a very challenging issue, and maybe, I don't know, Clement would like to comment further. I mean, except for progression, I don't know how really.
So all the myopia, there isn't, I asked the myopia experts and they don't have a good definition of myopic optic neuropathy, glaucoma versus non-glaucoma. It's not very, very clear. Right now, a lot of it's based on disc appearance, but the myopic disc is, it looks cupped, it looks pale, tilted, sometimes it's tilted, it's
hyperemic.
Yeah, it's almost impossible. So I think one thing that may be useful, and this is just my personal musing on this, is looking at if you can get OCT of the retinal nerve fiber layer using looking at the Brooks membrane opening and the thickness of the neuroretinal rim there. Right now, there's been some publication about how that differentiates between glaucoma and non-glaucoma. And so that may give us a better clue, but the problem is there's no single cut-off. Again, it may have to be a matter of progression. So matching that with progression of fields or not, you know, that may be a progression. The challenge is, of course, if there's a coexisting maculopathy, then all bets are off. You know, and You know, sometimes as a Hail Mary, you just give them some glaucoma medicines and keep your fingers crossed.
And even their corneas are thin, so the intraocular
The pressure
pressure,
measurement.
you can't get the actual value. And that's a really difficult one.
I think in normal pressure glaucoma, they are talking a lot about the intracranial pressure. These patients have a low intracranial pressure, and the normal IOP, there is a lot of pressure gradient across the lamina cribrosa, and that is one of the factors which causing the dysfunction of this.
Yes, that's correct. They
So
call the
that is one of the factors they're
translaminar cribosa pressure difference is the. But again, the one thing that we are not able to do is serial measurements of the intracranial pressure. that one we are not there yet. So we only can measure the intraocular pressure and guess at that. So again, it's that OCT. If you see a thin laminar cribosa, then exactly you may be correct. Exactly that. And posterior bowing of the laminar cribosa, then yes, possibly your IOP is higher than it ought to be. But this is not quantified yet, so we don't really have an answer for this. Yeah, hopefully soon.
Yeah, I think that concludes. I think just about a minute to go, and I'd like to invite you all to the Indian Neuro-Ophthalmology Society meeting this year at Jaipur, September 6th and 7th. Yeah, see you all there, and we have a couple of instruction courses following up in the same room here. Thank you.
The panel and the speakers for a photograph.